Hi, welcome to Iron Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all kind of different health issues with different experts in the field. Today, we'll be talking about ENT and children emergencies. So sit back, relax, and enjoy your time with us. Children are often found to have problems with tonsils, grommets, and blocked nose. This is quite normal for that age group, but if these conditions become worrisome, you need medical advice from specialists in the field. The ear, nose, throat or ENT is a specialty unit which deals with it. This is a within medicine that deals with the surgical and medical management of conditions of the head and neck. There are a lot of conditions affecting head and neck, but we are going to concentrate on children and their ENT problems today, and this is very common among the age group. Mr. Richard Milard, who is a consultant ENT surgeon in Essex. Hi Richard, thank you for being with us in the show. What do you do generally?
I'm an ear, nose and throat surgeon. I was trained in Cambridge and London. I've been working in London and Essex, as you say, for some time. So I deal with ENT issues, so ears, otology, nose, rhinology, and head and neck surgery and laryngology, which is the voice box surgery of the neck, and in adults and paediatrics, so adults and children. And ENT has quite a lot of paediatric child issues, as you just explained. Tonsils, adenoids, grommets are the commonest ones. Obstructive sleep apnea is common, and so on and so forth.
This is a really very serious job what you do, isn't it?
Yeah.
Ear, nose, throat, it's like there are lots of things there. The brain is there, the breathing.
Yeah, the brain is more neurosurgery, but you're in, I mean, when you're dealing with ear surgery or nasal surgery, you get close to the brain potentially. So you've got to have done a few, you've got to know what you're doing. But the majority of it, especially in children, is very straightforward and very safe. More rarely you can get more complicated issues with childhood airway problems. That can, I mean, you're an anaesthetist, that can, as you know, can get a bit more hairy. But the standard ear, nose and throat paediatric surgery is straightforward.
It's straightforward.
A lot of it is day case surgery.
Right.
Because they're children, especially if they're small children, you need to be careful, you need to have a good relationship with the anaesthetist. But the vast majority of it is very safe and very straightforward.
Very safe and straightforward. Okay, that's good. Let's talk about ENT today. Okay, excellent. Well, sometimes we have these problems. You know, children, while they're sleeping, they're very noisy, they snore a bit, and call it sleep apnea or something like that.
It's a common problem in its milder form. So we call it obstructive sleep apnea because most children, especially smaller children, will have relatively large tonsils and relatively large adenoids. The adenoids are like the tonsils, but they're at the back of the nose. And they can cause a degree of obstruction in the day, but especially at night. So you can get quite alarming seeming symptoms where the child can snore loudly. Your child may stop breathing just for short periods of time, often only a few seconds, but that can happen many times a night. And that can result in poor quality sleep and can result in the child getting drowsy during the day. Now, that's on the more severe end of the spectrum. Most obstructive sleep apnea in children, small children, so usually less than 5 years old, is mild. So they may have these symptoms to a mild degree, and it may be more pronounced when they have a cough or a cold, because children get lots of coughs and colds and their nose gets blocked up, and that can exacerbate the symptoms. So it's usually mild, but certainly if it does get more severe or if you get worried, you need initially to go to your GP, and then he may refer you to an ENT surgeon for assessment. And what we're really looking at is, does your child need to have his tonsils and adenoids, he or she need to have his tonsils and adenoids taken out? That will give more room for breathing, and that will definitely help.
Right.
Most children, you won't need to do an operation.
You don't need to do it
because you just need to keep an eye on them, make sure they're improving, because as they get older, the symptoms normally improve. Okay, but some children will need their adenoids and tonsils for consideration to be taken out, and that will significantly help.
Okay, if you are a parent, what precautions you should take during the night just
Well,
to observe the child?
You need to try and make sure your child's sleeping in a well aerated room. Using a humidifier can sometimes help. Sometimes using nasal sprays can help because that can reduce any inflammation, irritation in the nose.
Sprays.
Yeah, check for allergies, that sort of thing. Your GP or certainly an ENT surgeon will be able to do that. The things to look out for are lots of children snore. Snoring in itself is not so much of a problem.
Right.
Usually easily treated with a nasal spray. If they're getting these episodes, these apneic episodes,
that's the important one.
That's the A in OSA. That means they stop breathing just for very short periods of time. So it can seem alarming, but it's not usually dangerous, just for a few seconds. And if that happens a lot, certainly worth initially going to your GP and maybe seeking an ENT opinion. It's not normally dangerous, but it can, affect them in the day, and it can affect their schooling, and it can affect their growth if it's more severe.
More severe, right.
Often many parents do this. If you're worried, before you see your GP or an ENT surgeon, just take a little video clip of your child at night.
That's good.
That's very useful for the surgeon. You bring in just a 10 or 20 second clip saying, this is what my child is like most nights or now and again. And you can see very quickly, if you're the ENT doctor, if you're the GP, you can get quite a good idea roughly how bad the problem is.
That's a really
so that's
good
a very
point,
simple, useful thing you can do that gives a lot of information.
Yeah, that's really good point about the video. Even I haven't thought about that video.
Lots of children do it. It's a simple thing to do. You put your phone on with the sound on because you want to hear the noise the child's making. And just a 30-second clip or a 2-minute clip.
Record from chest and about?
Yeah, exactly. Just record the airway. And you want to see how the chest is moving, and and that's a very useful thing you can do, a very simple thing you can do, and that's a lot of useful information for the doctor, and that will that allows us to make the decision. Vast majority of cases there's nothing to worry about here, but what we're really thinking is, do we need to do something like take the tonsils and adenoids out? That will give a lot more space for the child to breathe, but it's, even though it's a very simple, safe operation, it's still an operation, and you don't want to do it unless you have to.
But tonsils and adenoids, as Ivan said in the do they need in that age? Or
no, you can do without your tonsils and your adenoids very easily. As you said in the introduction, they are part of the lymphoid system. So there are lymph glands and lymph nodes that are more prevalent in certain areas of the body, in the groin, in the neck, and there's a ring of lymphoid tissue which the adenoids are part of. The adenoids are best thought of as basically they're like the tonsils, but they're at the back of the nose. And you get to them through the mouth when you take them out, exactly as you do with the tonsils. So you have this adenoid tissue at the back of the nose, which if it swells up can cause nasal blockage. You have the tonsillar tissue, which is at the back of the tongue. You can see if you look in your mouth on most people. And then at the back of the tongue goes back a lot further than what you would think. When you stick out your tongue, you're only seeing about a third or half of the tongue. The rest of it goes down the back of the throat. And there's lymphoid tissue there as well. So if you take, and that's for protection against sort of bugs that you inhale or that are in food, but there's lots of that lymphoid tissue. So if you take the tonsils and the adenoids out, if you have to, you still have lots of other lymphoid tissue at the back of the tongue and
they will still protect them.
And that will still protect them. So if the tonsils and adenoids are getting a lot of infection, or they're causing a lot of obstructive problems, we sometimes recommend taking them out.
That's right.
And you can do without them. It's not a problem.
You can do without them.
It's not a problem.
Yeah.
It's like the appendix. You can do without the appendix. You can do without your tonsils.
Tonsils, yeah, that's a good point, yeah. Let's talk about throat pain. Is it very common in children?
Throat pain is, I wouldn't say common in children. Well, I suppose it is common. I mean, kids get lots of throat infections, okay? That will cause throat pain. That is a normal part of growing up. I mean, anyone who has children at nursery or in school knows that a lot of the time they're going to get coughs and colds. And that's okay, because that's how the immune system can develop. But if you're getting a lot of tonsil infections, again, you might consider aiming to take the tonsils out, but you need to differentiate between tonsil infection, which is relatively uncommon in children, lots of it, and between pharyngitis. That's just an infection of the throat, that's a sore throat. So a sore throat does not have to be tonsillitis. And you can normally get that by asking, as the ENT surgeon, asking certain questions. So not all sore throats are tonsillitis, but tonsillitis may play a role.
Play a role, isn't it?
Yeah, it's possible.
Okay, there's a quick question. Why don't GPs give antibiotics for this throat pain? Somebody asked me
That's a good question. I do feel a bit sorry for GPs because they are often demanded to give antibiotics. And the simple fact is, especially in children, most sore throats, most tonsillitis will be caused by viral infections. Nothing to do with COVID.
So it's viral infection.
Simple viral infection, the same sort of infections that cause colds as well. And they are viral infections, and they won't respond to antibiotics. It may seem like they respond to antibiotics because you will go with the viral infection, you may get given antibiotics, it will get better. But probably it's going to get better anyway. Okay? If you get a more severe infection, where you get a viral sore throat, and that goes on for more than a few days and starts getting worse rather than getting better, then you may need antibiotics. Because then you might have a bacterial infection on top. But most sore throats are caused by viral infections, and they will get better within a few days. No antibiotics are needed. What you need is, Calpol, ibuprofen. Keep the child, same as for an adult, keep the child, well hydrated. Encourage them to eat and drink, and they'll usually get better within a few days. If they don't, then you might need the antibiotics.
Hi, welcome back to Iron Health Talk with Dr. Akram. Today we are talking about children ENT problems. So far we talked a little bit about the sleep apnea or obstructive sleep apnea in children, and it's going to talk more about adenoids, tonsils and grommets. But we're going to play a video. This is kindly provided by Children's Hospital, Colorado. This is about how the tonsils and adenoid surgery is done in children and how they reach the hospital and what they do and about their discharge.
Sometimes a child's tonsils or adenoids can get infected over and over or become so large that they cause trouble swallowing, breathing, or even sleeping, and may need to be removed. Tonsils and adenoids are part of the lymphatic system, which help your immune system fight infection. Tonsils are on both sides of the back of the throat behind the tongue, and the adenoid is behind the nose. Your tonsils can be seen through the mouth, but the adenoid is hidden. Tonsils and adenoids help fight infection from the germs that enter through the nose and mouth. Sometimes an infection can cause them to swell. There are two main reasons why the tonsils and adenoids may need to be removed: if they continue to get infected over and over, or if they become too large. Tonsils and adenoids that are too large may cause difficulty swallowing, trouble breathing, or may interfere with sleep. When the tonsils are removed, it's called a tonsillectomy, and when the adenoids are removed, it's called an adenoidectomy. The surgery happens in an operating room. First, your child will be given general anesthesia, a medication that makes your child sleep, keeping them from remembering or feeling any pain during the operation. After your child has fallen asleep, the surgery begins, which usually takes 45 minutes. During a tonsillectomy, the mouth is opened to locate the tonsils and uvula. Each tonsil is grasped, removed, and then taken out of the mouth. During an adenoidectomy, the mouth is opened to visualize the adenoids. Then the adenoid is removed and taken out of the mouth. After surgery, most children recover in the hospital for 2 to 4 hours before going home. But some may have to stay overnight and go home the next day. Your child will have moderate to severe pain in their throat, which can last 10 to 14 days after the procedure. They may also complain of pain in their neck, jaw, and ears. Often the pain will get worse before it gets better. Most children get back to school or daycare about 10 days after surgery. Physical activities are limited for 2 weeks after surgery, which means no rough play, contact sports, swimming, or travel. Make sure that your child gets plenty of rest and that they drink plenty of fluids and take their pain medication as prescribed.
Let's talk about tonsils. Why do we... So we talked a little bit about tonsils, right?
Mm-hmm.
And you said it's not really important that we the tonsils in that age. But if it has to be taken out, and they will come to you, isn't it, as an ENT surgeon?
Yeah. In children, there are two main reasons for taking tonsils out. The commonest is, as we talked about earlier, obstructive sleep apnea.
Obstructive sleep apnea, yeah.
Large tonsils, nearly always enlarged adenoids as well, because if the tonsils are enlarged, the adenoids will also be enlarged. That's invariable. The adenoids are at the back of the nose, so you can assess them in clinic either by putting a little telescope into the nose, okay, and having a look.
So you can see them in the clinic. They don't
the slightly more old-fashioned way is to do an X-ray, but these days we can normally look in the back of the nose in the clinic with a very small telescope. That'll tell you immediately. But we know almost for certain if a child has obstructive sleep problems because of large tonsils, they are almost certainly going to have enlarged adenoids. And if we feel that they therefore need an operation because the symptoms are on the more severe end of the spectrum, you normally take the adenoids and the tonsils out. Okay.
Both of them, yeah.
That's done through the mouth under a general anaesthetic. You can get the adenoids. You can get to the adenoids through the mouth as you do with the tonsils, and you nearly always these days go home the same day. If the obstructive sleep apnea is more severe, you may well need to stay overnight.
Stay overnight.
Stay overnight.
That's because of anaesthetics and all these drugs.
That's because, as you know, of anaesthetic issues.
And the drugs.
Because they need to stay away from large groups of other children while it heals up. Okay, not because they'll be unwell, but just while things heal up.
That's just to prevent any infection or anything
exactly,
further
because you're at school, you're mixing with, 10, 20, 50, 100 children. So you don't want them necessarily to get an infection while things are healing up. But you should find in the majority of cases your child is going to be running around the next day or 2 days later.
So even if, during this infection going around, this COVID-19 everything, still you do these kind of operations?
Well, it depends where you're working and how many COVID cases are in, but as you know, the COVID patients tend to be separated off. So, but yeah, these surgeries are still going on because if you have a child who needs an elective operation, not an emergency operation, an elective operation, there's a good reason why they need the surgery. So although you may find some delay in the waiting list, I mean, we're still doing these operations.
So as an ENT surgeon, you deal with ears. Well, ear infections, are they common in these children?
Ear infections are common in children. Okay, the reason for that is there's a couple of reasons. The children get lots of coughs and colds, as we said earlier. That's a normal part of developing the immune system, and just that's fine. And consequently, they also get quite a lot of what are called middle ear infections. Okay, more than adults do, as any parent knows. Children get earaches. Some more than others, but earaches, and that's because they get a cough or a cold, and there's a tube called the eustachian tube. That's the tube that equalises the pressure in the ear, okay? And that opens at the back of the nose, okay? It starts behind the eardrum. And it in what's called the middle ear, and it opens at the back of the nose. And so if you get a cough or a cold, you can get infection going up that tube into the ear. That's why when you get a cough or a cold, your ear often feels blocked up.
Right.
If it's on a nasty cough or a cold, that's why. And children get lots more coughs and colds, and the tube, the eustachian tube in children is much shorter than adults and a little bit wider. So you've got two things: lots of coughs and colds, a shorter tube, so the bugs, normally a viral infection, go up the tube, and then you get an ear infection.
Ear infection, yeah.
And that will normally resolve quite quickly. Okay. The other thing children get is what we might talk about now or maybe later is glue ear.
Glue ear, that's right.
Now that is an infection. If you get lots of infections, as I've described, that can cause glue ear. But glue ear is fluid that gets trapped behind the eardrum and cannot drain down the tube.
That's right.
And that's glue ear. And that's,
so generally, it drains down through the eustachian tube.
Yeah.
So if that gets blocked,
because behind the eardrum there's a closed space apart from the tube.
Exactly.
Okay, and if that gets blocked up, you can get this fluid called glue. Sometimes it's sticky and it does look a bit like glue, but not always. So you've got a sort of constant feeling of a blocked ear, and that can affect your hearing. And that's glue ear, which is much you can get it in adults, but it's much commoner in children, especially between the ages of 2 and 5. 2 and 5.
Yeah. And that's the time they come to you, isn't it?
Yeah.
So what's the correct part? So if some parents have this kind of problems, do they have to go to GP?
It often goes along with nose and throat problems as well, especially nasal blockage. And the child, usually get a mild hearing loss. Okay, so not a severe hearing loss, but you get a mild hearing loss, which can be important in terms of schooling. Okay, it's very easy to diagnose, often just by looking in the ear, but then we also do a hearing test as well. And you can see that there's a certain type of hearing test which you can see the fluid behind the eardrum. It shows up on the hearing test. Now that doesn't mean your child will need grommets.
Grommets, yeah.
Grommets are a treatment we'll talk about in a bit for glue ear, common operation. But if the glue ear persists for more than a few months and the hearing is affected, that's when you sometimes consider putting grommets in. But having fluid behind the eardrum, glue ear itself, is very common. If you just went out and got 100 2-year-old children, at any one time 5-10% of them at least will have fluid behind the eardrum.
Fluid behind the eardrum, yeah.
Because that's sort of almost a normal part of growing up. But it's only if that fluid persists for more than a few months and it's causing hearing issues, then you might think about doing a small operation to drain the fluid off. But you don't normally do that immediately. You normally you do sort of 2 hearing tests 4 to 6 months apart.
Okay, so if the parents identify these hearing problems, they need to go to the GP, and the GP will refer to you.
And the fluid will normally drain away by itself. So often you will see the child back and the fluid will have gone. But then if it doesn't, then you might think about doing a small operation to drain the fluid.
So how
How
is this operations performed? So what do you basically do? Is this a small operation?
It's a small operation. No real risk of bleeding, as we talked about with tonsils and adenoids. A small operation done as a day case. You do need an anaesthetic. In an adult, you can do it under local anaesthetic, but children need to be asleep because they will move.
They will move, right.
What you do is you use a microscope, and you make a tiny little cut of just a few millimeters at most in the eardrum, and you use a micro sucker just to suck out the fluid, and then you put a little plastic tube, which is called a grommet in this country. I mean, in the States they're called ventilation tubes, VTs.
Ventilation tubes.
Because that's what they are. They're tiny little things, about the size of if you think of a sort of a nib of a biro pen, just the bit at the end, they're about that size. Okay, they're small.
It's very tiny.
Because you don't want to damage the eardrum.
Oh, that's right.
And you make a tiny cut with the microscope, you pop them in, and do the same on the other side normally. Child will go home the same day, and you should notice a difference quite quickly.
Right.
And the grommet itself will normally work its way free after about a year, 6 to 18 months. They work themselves out and they come out, and the eardrum will normally heal up.
So that will just fall off?
Yeah. And by then, your child will have probably grown out of the problem, because glue ear gets a lot less common sort of after the age of 5. Not always, but usually. So I say that about 20% of children who need one set of grommets might need another one. So in other words, most children won't need grommets. Children who need grommets, it is still a common operation. Most of them won't need another set. but some will need another set.
Hey, welcome back to Eye and Health Talk with Dr. Akram. Today we're talking about ENT procedures in children. So far we have talked about obstructive sleep apnea, tonsils, tonsillitis, tonsillar surgeries, and of course grommets insertions. And let's talk a little bit about blocked nose. Is it very common?
It's common. All these things are common.
Oh, yes, exactly.
All these things are common. Blocked nose in children is common. It's often due to, there are two main things I would say, especially in children, that can cause a blocked nose. One is what's called rhinitis. Rhinitis is inflammation of the nasal cavity.
Inflammation.
Okay? So when you have a cold, your nose feels congested, might feel itchy, that's called rhinitis. The inside of the nasal cavity is inflamed because of the common cold virus. Okay? Now there are different. So children get a lot of colds, that can cause rhinitis, that can cause nasal blockage, but that's normally intermittent. They will get better in between times. Some of them will have a more persistent nasal obstruction. Now that can be due to allergic rhinitis, again very common in children. The commonest form is hay fever.
Hay fever.
Okay, you're allergic to a certain type of pollen, maybe more than one type of pollen, and as anyone who gets hay fever knows, that can cause nasal blockage, and hay fever is quite common in kids. Allergy to house dust mite is also quite a common cause of an allergy, and then you can get allergies to cats, dogs. Food allergy is a little bit more complicated and controversial, but obviously certain types of food can cause issues. But it's normally pollen or pets or house dust mite, which is dust, which is, however you try and keep your house, there will be some sort of dust around, and that can cause inflammation in the nose. It's more common in children who have significant asthma, and it may be more common in children who have eczema, because all these things are sort of inflammatory conditions that are partly due to the immune system, and that's managed normally not with surgery but with medical treatment and with allergen avoidance. So, try and reduce the amount of house dust mite. Don't go, be cautious when this pollen that you're allergic to is in season. So allergen avoidance, that's key. And then in terms of nasal obstruction, it's normally nasal sprays. Okay, so nasal washes and douches, which is often just saline, salt water, or your doctor may give you what's called a nasal steroid spray. So a classic nasal spray. That just acts locally within the nose. Right. Can be a bit of a tricky thing to learn to use, but you can look at these things up online for the best way.
That's a good point. Yes.
Lots of things. Just look it up, because the issue with nasal sprays often is, my nasal spray's not working. We've taken it for ages, it doesn't work. You do have to persist with them, because they may not work straight away. But the other thing is, look up or read the instructions, or just look up online. It's the same with an asthma inhaler, but that's a little bit different. But it's vital to use them correctly, which can be a bit tricky, because it's quite easy to sniff very hard and all the stuff shoots through your nose, ends up in your stomach.
Exactly.
It's not going to work in the nose.
It's not dangerous. To work in the nose, isn't it? It's not inside.
Yeah, alternatively, you can sniff not enough, or you don't point the thing into your nose properly, and then you get it at the front of the nose. Yeah. And that causes irritation, okay? And you can just look up, or get your doctor to show you, or look up online or read the instructions how to use it, because that's vital. And that will solve most problems of rhinitis. Okay?
Rhinitis, that's it.
The other common cause is, we talked about before, enlarged adenoids.
Adenoids,
okay? So enlarged adenoids can cause nasal blockage.
Oh, that goes back of the nose.
And that can be diagnosed by looking at the adenoids. And that often goes along with rhinitis. So if the front of your nose is inflamed for the reasons we've just said, that can also cause the adenoids to enlarge.
Septal defects, they're not very common in children?
Septal defects are much less common in children. The septum is the bit here, the cartilage that runs back and separates the nose into two halves. It's not actually that common to have a septum that's completely straight. So most people's septums are deviated a little bit. So that doesn't mean that's causing the nasal obstruction. If the septum's completely deviated, then yes, that may be a problem, and that could be fixed with a small operation. But we don't like to operate on children's noses in terms of the septum, usually. Sometimes we do, but the reason is the child's nose is still growing.
And
we're cautious about taking out bits of cartilage that might affect the growth of the cartilage. Okay, it can be done, but you have to be a lot more cautious than you are in adults.
Even though we think these children they grow proportionally, but not all the organs grow proportionally at the same time. Some grow faster, some grow slower. So you have to be. But again, bleeding is not very common, especially in children, unless they have a trauma.
Well, bleeding with the surgery is not that common. Nosebleeds in children is very common.
It's very common.
It's one of the commonest things that you see children for in ear, nose and throat, and in general practice. Nosebleeds in kids are common. It's normally self-limiting. Okay, so it's it doesn't normally cause ongoing issues, but it can be quite distressing, because even a small amount of blood can look like a lot of blood.
Exactly.
Which can be distressing, and it can be incredibly inconvenient, because if your child is having lots of nosebleeds, you may get being called by the school, every other day saying, so and so's had a bleed again.
So when to seek help? What is the cut point there?
The three things, most important thing, simple first aid. And you can teach your child to do this if they're more than 3 or 4 years old. Press on the soft bit of the nose, lean forward, don't lean back, don't press on the hard bit. That's the simple thing to do, simple first aid. Next thing to do is your doctor, ENT surgeon or GP may give you a cream for the nose.
Exactly.
And that will settle down any infection that's in the nose. If that doesn't work and there's still an issue, worth seeing an ear, nose and throat surgeon and having what's called nasal cautery. Nosebleeds in kids will normally come from the front of the nose, the front of the septum, in here, on the inside of the nose. And you can see that area very well in clinic.
In clinic, yeah.
And you can spray a bit of local anaesthetic, and then you get a little stick called a cautery stick, which has a little chemical on the end, and you can press that on the nose where the blood vessels are and seal the blood vessels off. Okay? It's a little bit uncomfortable, but vast majority of children aged 4 to 5 and above will be able to tolerate that.
They'll be able to tolerate it.
Yeah, and that's something, your GP won't normally do that. That's something that normally will be done by an ear, nose and throat surgeon.
Richard, thank you very much. I think this is really
Pleasure.
good information you provided us even in this short time, and we have covered most of the children ENT problems. Especially we talked about sleep apnea, we talked about tonsils, adenoids, grommets, nosebleed, and a bit more. Do you have any special message for our viewers?
In terms of what? In terms of
ENT, and especially in your area?
No, I would say don't hesitate. The vast majority of ear, nose and throat problems in children will be self-limiting and not dangerous, and will not cause long-term problems.
Long-term problems.
But you must not hesitate to get in touch with your GP, and then, if necessary, ask for an ear, nose and throat consult if you're worried about any of these things, because they will sometimes need treatment, and it's normally a very easy thing to treat that can be done with very few side effects and has an excellent chance of benefiting your child significantly.
Thank you very much, Richard. It's our pleasure to have you here.
That's a pleasure to be here.
Really covered you. Provided really very good information for our viewers, and Richard Milard is a consultant ENT surgeon in Essex, and he has provided us a lot of vital information. So we're going to come to the end of the program. Thank you for being with us, and hope to see you in some other program with us.
Yeah, I'd be delighted. It's a pleasure.
Okay, anyway, for you, today we talked about ENT, especially in children, and as we said again, we have covered most of it, and if you have any further questions, you can always message us on our YouTube channel underneath, and we will come back to you. And for time being, we're going to say goodbye, and we'll see you next time. But by the way, next time we're going to do a special program on how to get into UK medical schools, and this is we're going to bring a few university students, and they're going to say their first-hand experience, how they've gone through and how they succeeded. So be with us, and next time it's going to be a live program as usual on our Thursday from 8:30 p.m. to 9:30 p.m. on 24th exactly. So until then, look after yourself. Thank you very much for being with us. Take care. Bye-bye.